My name is Eileen Cheever. I'm a dermatology PA at Clearview Dermatology in Central Massachusetts. Also very proud SDPA member and very, very appreciative and happy to be here to speak with you on behalf of Lilly. So we're going to be covering a topic today surrounding biologic updates for patient-centered care. And no surprise, the real focus of this deck is going to be itch. We're going to take a look at the approved biologics in the space for AD, look at their efficacy and their safety, and then we're going to take a look at what deep and stable response means for our patients who are on biologics who have AD, and really help use that information to guide that next conversation you have in that room with that patient who you're considering for a biologic for their atopic derm. I think both of these concepts obviously are very much interrelated. How do you ask your patients about itch, and why do you ask your patients about itch? Everything you're seeing on physical exam supports that they are looking great. And then because we're all such steward clinicians, you then lean in, you sit down, you say, how are you feeling? How's that itch? And either they say, great, thanks for asking. Nobody ever asked me about my itch up until coming here. Or, it's a just absolute puddle. These patients say, I'm not doing as well as I could be. The itch is driving me crazy. So we need to have a way, whether it be standardized in terms of NRS or a way that you're always checking with your patients about how they're doing. Okay, so let's review and briefly cover again some of those cytokines that we see that impact skin inflammation and itch in our AD patients. We know there is not one silver bullet that is the one and only driver of inflammation and itch in our AD patients. We know that it's multifactorial. We know there are a lot of different cytokines that are here at play. And when we look at the state of our patient's skin, whether it be healthy, or maybe a patient that has AD, but it's non-lesional, and then of course our patients who are in acute flare, or our patients that are dealing with long-term chronic disease, we know that alarmins are at work as well, whether it be TSLP, et cetera, who are again just propagating this inflammatory state. And when we look at these patients who are in chronic disease, we know that our chronic patients can be often harder to treat. And that's just not the length of disease they've had, but that's also because there are some cytokines that are propagating that inflammation in that chronic patient. When we take a look at it from a neurogenic point of view, many of the concepts are the same, but it really focuses on what we know as the itch-scratch cycle. These patients are scratching, it increases the release of serotonin, it increases expression of that IL-13R alpha 2, and we know that this causes more uptick in those sensory neurons that are continually passed through the dorsal root ganglia, through the spinal cord and in the brain. So the next few slides are going to individually review the current FDA-approved biologics for atopic dermatitis. We all know that dupilumab binds on that type 1 receptor to the IL-4R alpha, and that helps inhibit that IL-4 activity. It also binds at the type 2 receptor, and when it does that, it also influences the manifestations of IL-13 mitigated disease as well. When we look at lebrikizumab binds to the IL-13 cytokine itself at an epitope that prevents that IL-13 from allowing that heterodimerization at the receptor site, which is that step that really helps propagate that downstream inflammation. And it binds at an epitope that allows IL-13 to not only interact with that type 2 receptor, but also interact with that dummy decoy as well. When we look at tralokinumab also binds to IL-13 at a different epitope. Again, not allowing interaction with that type 2 receptor and the inflammation that happens, but also does not allow interaction with that decoy receptor. And last but not least, nemolizumab, as we know, binds to that IL-31R alpha receptor, does not allow IL-31 to engage and hook up with that type 1 receptor. Take a look at some of the standard data endpoints for those biologics we reviewed a moment ago. This first slide looks at dupilumab monotherapy with skin and itch response at week 16. This is an itch conference, so we're going to spend the next few moments reviewing a lot of itch data points. where you can see the itch improvement with dupilumab as well as the statistically significant improvement in that daily peak pruritus scale. Same thing, Tralo's data for skin and itch response, Tralo monotherapy at week 16, honing in on that itch improvement with a 4-point or more improvement, as well as the worst daily pruritus improvement for tralokinumab. This is the slide that reviews the data for nemolizumab. Keep in mind, this is Nemo plus a topical corticosteroid and or a topical calcineurin inhibitor. This was not monotherapy. This is week 16. And honing in on that 4-point or more itch improvement versus placebo, as well as their worst daily pruritus improvement compared to placebo. Looking at improvements in skin and itch response, lebrikizumab at week 16, monotherapy, no topical corticosteroids, no topical calcineurin inhibitor, EASI-75 numbers at week 16, but again, focusing in on itch, that separation between the lebri group and placebo, and seeing some improvements in terms of what the daily pruritus NRS score improvement looks like. We all know AD on the hands can be notoriously difficult to treat, but also incredibly impactful for our patients. Not only does it look this way, but imagine what it feels like. And this case really does illustrate that. Their baseline EASI 30.2 with an itch of a little under 6. And we look at them at week 16, and photographically, I think the story is told itself, but with an itch NRS of absolutely 0 and some really beautiful improvement with EASI. Safety slides, to be fair and balanced, not the target of today's conversation, but here are the adverse reactions in 1% or more of patients on Dupi at week 16 versus placebo. Following along the safety information for all of us to be aware of regarding tralokinumab up to week 16 in 1% or more of our patients. Nemo plus topical corticosteroid or TCI reactions 1% or more up to week 16, as well as the lebri 1% or more data up to week 16. So deep and stable skin and itch response in the long term. You know, I get this question quite a bit. How important is it to you that a patient feels less itchy in 48 hours? And I always say to the person that asks me, that's really hard because I've never had that type of itch that I've wanted relief so quickly. It's hard for me as a clinician or even as a patient to say, I don't know how that itch impacts me so much that would 48 hours be something that impacts my life or not. I think there are a lot of patients out there that want that relief as soon as possible. But in my experience of treating a lot of atopic dermatitis patients, that's the cherry on top. But my patients want to know that they are going to get better in terms of their itch and frankly, feel better in the long term and have that day-to-day, week-to-week predictability that their itch is going to stay under control. And really, in my experience, as time has gone along, long-term durability and stability of itch control has really moved as my front horse in terms of what I'm looking for regarding itch in the long term. And we know what that means, that predictability, being able to tell our patients that I have great confidence that the drug I'm going to put you on is going to give you that itch control that you can rely on and you can predict. Of course, we know atopic dermatitis is a very heterogeneous disease. It's very difficult to treat, and that's why there's so many wonderful options for so many of our AD patients. Not everybody fits into that one bucket, but being able to talk with our patients about setting a goal for stable itch response. And I want you to keep me posted about, sure, how you're doing day to day, but week to week. How are you doing compared to a month ago? How are you doing compared to 6 months ago? Are you feeling better? Are you feeling the same? Are you feeling like you're losing that stability a little bit? I'm always setting the table to let my patients know that not only do I want to know how you're looking, but I really want to know how you're feeling long term, and we have to pivot accordingly. This first is tralokinumab, and this looks at stable therapeutic response up to week 152. And just to have everybody kind of be familiar with what the term stable therapeutic response means as it pertains to these next few slides, it means that more than 80% of the visits that these study participants attended, they had an EASI of 7 or less, a worst weekly pruritus less than 4, 80% of the time that they were at those visits as observed. This is also that similar definition of stability. And when we look at stability and measure it out to week 104 with lebri and looking at those data numbers as it pertains to the EASI score as well as pruritus. And we see each one of those dots, which is really amazing to think that one of those clinical participants is right there on that screen, and we're watching their journey in real time with that video to see what their journey is in terms of for their easy accomplishment as well as their improvement in pruritus. And that dotted line really represents that level of stability with easy 75, as well as improvements of itch with a itch score of 4-point or more improvement. And we see the majority of those study participants dive below and stay below that line in a really stable, predictable manner. And I think, this next set of questions really talks to about being able to set expectations with your patients and being able to guide your patients in terms of what treatment is most in line with what their treatment goals are. And we think, our patients think they know what they want, and I think a good degree of them do. But I always keep in the back of my mind that some of these lifelong AD patients cannot even think of, like they can't think of what life could be like to be 75, 90%. We're talking about biologics with 100 data. What it's like to possibly live their life with their AD under control. And sometimes these patients, they set their bar so low, can you maybe just give me a cream so that when I'm less itchy, I feel a little bit better. So some data here for Dupy EZ90, looking at that at week 100. Trelo EZ90 as well. And then talking about Nemo plus the topicals, we look at EZ90 at week 56, and then their clear or almost clear itch score out at week 48, and following those patients' journey with their itch and EZ90. This slide shows the ability of lebrikizumab to get EZ90, EZ100, in patients who have absolutely no itch or next to no itch. And following these patients' journey, not only out through week 52, but continuing to follow those patients on that Q4 week dosing and look at those numbers for EZ90, EZ100. And don't be afraid to dream big with these patients because, again, some of them can never even imagine what it's like to live their lives without this degree of AD. So I know we all do it, but just keep fighting for those patients every day. Thanks so much for attending, and I'll take any questions.
During this activity, I am a contracted speaker for Eli Lilly and Company. Additional conflicts of interest include consultant and/or speaker for AbbVie, Arcutis, Beiersdorf, Bristol Myers Squibb, Dermavant, Eli Lilly and Company, Johnson & Johnson, Leo, and Sanofi Genzyme Regeneron.